I don't see Olo on the line.
No, he emailed me about a half hour ago. He should be coming in. And you got the link without a problem, right? Here we go.
All right, here we go. Olo, how are you?
Hey, Dr. Carlson, how's it going?
Good, good. Looks like you just stepped out of the OR.
Yeah, not too long ago. Well, about an hour ago. Good to go.
Hey, Olo, how you doing?
Hey, how's it going, Dr.
I'm Randy D'Amico.
Yeah.
We've been in contact.
Yeah. Thanks for everything. Thanks for organizing all of this. It's a great thing you guys are doing here.
It's fun. We started this originally in COVID as kind of a way to talk to patients. And then, I kind of just kept it going, and I reached out to Jason from the JNO, and I was like, you guys aren't doing this. No one's really doing it. Why don't we just have this virtual journal club? And he was like, yeah, all right, sounds good. And to be honest with you, it forces me to take a half hour, or more. And I just read the papers. I get to stay on top of things. I get to meet everyone, which is awesome, right? Because you get to stay in touch with people who are doing this stuff. And it's great. And we, the subscribership on the YouTube channel has gone up little by little. It coincided initially with a program that I had started here called Brain Turns. And so when we first started, we were getting 500 people viewing every session. Those numbers have dipped a little bit, but if you look at the chronic rewatches, this stuff all exists on the internet now, and people can check it out whenever. So it's pretty useful. It's pretty fun. Hey, Jason, how you doing?
Hi, Jason. Good to see you.
Thanks for coming.
So it's 4 o'clock. Why don't we get going? Olu, you want to just share your screen?
Yeah.
So welcome, everyone. Welcome to another edition of Tumor Talk. We took 2 weeks off there, but we're back. And we're very excited today to have a number of very special guests. Olu Akinduro and Zia Gukaslan coming, with a paper that I think is pretty well done. It's a meta-analysis looking at cervical chordoma. It was a collaborative effort between 3 big institutions. And I don't want to spoil it too much, so I'll let them kind of introduce it. But welcome, guys. We're really excited to have you.
Yeah, first of all, thank you once again for doing this. I mean, it's exciting to see all the research that's coming out, and I look forward to seeing more of these in the future. So like you mentioned, my name is Olu Oluwaseun, but I go by Olu Akinduro. I'm a 5th-year neurosurgery resident at Mayo Clinic in Florida. I'm planning to go into spine oncology / minimally invasive spine. That's why I had to, of course, recruit the help of Dr. Gukaslan, who's one of the biggest names in spinal oncology as we have here. So this publication is called Cervical Chordomas. So it's a multi-center case series as well as a meta-analysis. So I'll go ahead and get started. So the purpose of this, kind of the learning objectives, are to discuss the difficulty of cervical chordoma surgery and why this study is so important. We're going to discuss some of the surgical management options for cervical chordomas and why to select one over another, and then determine the effect of extent of resection on prognosis and survival in these patients. So just a quick intro, chordomas, as we know, they're the most common primary malignant spinal bone tumor. They're very well studied in the sacrum and the skull base in terms of kind of surgical outcomes. We know that in the sacrum, en bloc resection is the goal. But as far as the cervical spinal cord, it's not nearly as well studied. And of course, the surgery there is much more daunting. I mean, you have the vertebral arteries, the esophagus, the spinal cord itself. And there have been studies that have shown that there's a worsened overall survival when you compare these patients with cervical chordomas to chordomas in other areas. So en bloc resection, I mean, what is that? Basically, where you're doing a big tumor resection and going around the margins of the tumor to take it all out in one piece. And this is really the only way that we know that we have as far as potentially curing these patients. There really aren't any good therapies, actually no FDA-approved therapies for chordoma. So this is really all we have. But in the cervical spine, I mean, with all those structures there, I mean, it's nearly impossible most of the time to be able to do this successfully. And then now we have improved technology, you have proton beam, you have focused radiation. So the question is, are these big resections still necessary for these patients in this new age of improving technology. So our hypothesis here is that there is a significant benefit in progression-free survival and overall survival when you perform a gross total resection and get the whole tumor out. So, of course, Dr. Gokazem, I was fortunate enough to receive a couple of cases from him. These are just a couple of cases that he's done in the past. So I was going to highlight these to show the kind of intralesional gross total resection, as well as en bloc resection. So kind of give you an understanding of how we're taking out some of these tumors. And Dr. Gokazem, feel free to chime in, take over for these if you want to. So here, this is a beautiful picture. This is an endoscopic approach to take these out. So here you can see a beveled tubular retractor. Basically, you do an anterior cervical dissection and you dock this on the front of the spinal cord, on the front of the spine. And through that working channel, you're taking out the bone and then the tumor. Here, just a picture of the actual cannula that you're using. And here, intraoperative photo. So in the left screen here, you can see the stealth navigation. And of course, here you can see the camera for the endoscope. And here you can see, large tumor with some ventral compression of the spinal cord. And there, after the endoscopic resection, we're able to get out what appears to be a gross total resection. And here, this is kind of the other end of the spectrum, like an en bloc resection. Like I said, it's pretty rare to be able to, you're not always going to be able to do this in the cervical spine, especially in these situations. Here you can see the vertebral artery has been encased. So typically, obviously, you have to do an angiogram to determine whether you even can do this feasibly. So here, big picture showing a lot of anatomy. You got the vertebral artery on the contralateral side. Here, the right vertebral artery after ligation. You've got the tumor and all the cervical nerve roots. Here, just basically showing the posterior instrumentation. And here, transmandibular approach. You can see the hypoglossal nerve there. And back there is actually the tumor. So like I said, a very big contrast to a more minimally invasive procedure like I showed before. Here, the vertebral artery again. And here, just showing the reconstruction that was done, just to kind of stabilize this. You're going to need some anterior column stabilization as well. Here, a beautiful illustration kind of showing what's going on. So there you can see the anterior reconstruction. And this is a big surgery that you're obviously going to need help with ENT. You're going to need plastics. So definitely a multidisciplinary approach for these. And here you can see the en bloc resection. So now we'll get into the actual paper. So as far as methods, the case series that we did, it was collected from all three Mayo, so Florida, Rochester, and Arizona. Top right, this is basically just actually a picture that I took from the lab, some of my chordoma cells that are growing with the typical phyllosiferous cells is what the term is for those. So we included patients that had cervical chordoma resection, that had to have pathological confirmation of the diagnosis, that had to have complete records and an available MRI. We excluded patients that had tumors that had spread from anywhere else. This is important because chordomas, up to 30% of them actually metastasize. So we excluded anything that did not have a primary cervical chordoma. We excluded them that didn't have extensive resection and all the available information. And the way we determined extensive resection was using the postoperative MRI, as well as the pathology for the cases that had an en bloc resection. And then the meta-analysis, we included papers, of course, that included cervical chordoma patients. We excluded case reports, and they all had to have at least 3 patients to be included. And we did this is actually pretty unique. We did what's called an individual participant data meta-analysis. So what that means is, so when you think of a normal or a conventional meta-analysis, it groups all of the data together. So in certain situations where you have the individual patient data for every single paper included, you can do what's called an individual participant data meta-analysis. And the benefit of this twofold. Well, one, it's stronger, and two, you can look at time to event outcomes, such as progression-free survival and overall survival. So in any normal meta-analysis, you would never be able to look at some of these outcomes. So we collected all the variables you see there. So the groups were en bloc resection with negative margins, and then intralesional gross total resection. So we included the en bloc, so the patients that had attempted en bloc, but positive margins, meaning that the margins were violated with tumor, we actually included those in the intralesional gross total resection group, plus the the normal intralesional gross total patients. Then we had the subtotal resection patients. So because we know that the actual act of performing an en bloc resection, is very different. The approach, the way you are actually going to start the surgery and tackle it is very different. So we did an intent to treat analysis, which means that all patients who even had an attempted en bloc resection, we put them then into the en bloc group. So we did it both ways just to see if the actual act of performing the surgery made a difference at all on the outcomes. So here, just to kind of give you a pictogram to understand kind of what's going on with the different groups. B, you have an en bloc spondylectomy. So there you can see in the picture, the entire tumor plus the margins, you're trying to take that all out. Here, an intralesional gross total. So you're taking out the whole tumor, but you're taking it out in pieces. And then D, which is basically just a subtotal resection where you're not able to get the whole thing out. So here, I'm not going to dwell on this, but this just shows all the patients included in our case series, which is 22. There were 2 en bloc, 6 intralesional gross total. And we grouped, at least for the case series comparison, we grouped en bloc and intralesional gross total resection patients together. So in terms of progression-free survival, this is all descriptive. All the actual statistical analysis is in the meta-analysis. The numbers weren't high enough to do a good stats analysis, so this is all descriptive. So progression-free survival is 4 to 5 months for the gross total resection group versus 15 to 16 months for subtotal resection. So big difference there, obviously. And then in terms of radiation, we tried to look at patients that had high dose radiation and compared them to those who received just conventional less than 70 grays. And there was a little bit of a difference, 49 versus 31 months. Then here we looked at location. So upper cervical, meaning C1, C2 versus lower cervical. And we found that upper cervical cases, they actually had much shorter or less than half progression-free survival, almost 1/3, when you compare to those in the subaxial spine. We also looked at the use of chemotherapy, but there really wasn't a difference in that. It was pretty much identical, so I didn't include that. But then for overall survival, median overall survival was very different. When you look at patients with gross total resection compared to those who had subtotal.
Hey, Olu, sorry to interrupt.
Yeah.
When you look at upper cervical chordomas versus those in the subaxial spine, did that location also correlate at all with the extent of resection you were able to achieve? Do you think that had something to do maybe with the difference in survival and progression-free survival in those areas?
Yeah, great question. Actually, I'm going to touch on that quite a bit because we looked at all of that for the case series and also for the meta-analysis. And actually, right here on this, I think this next picture, yeah, here. So here what we did is we actually took all the MRIs and we did a volumetric analysis of their baseline tumor volume. And then we looked at what they were able to, the percent of extension. So for all the subtotal resection, the extent of resection was about 79%, but we found a moderate correlation between the preoperative tumor volume and the extent of resection, meaning the patients who had smaller tumor volumes at baseline were more likely to have an extensive resection. And then we also confirmed this data in the meta-analysis. So that's a great question, and it turned out that that was the case. So for the meta-analysis, here we had 12 studies that we found. When you include ours, that's 13 with 161 total patients. So there you can really see why we had to do something like this to be able to get any data. And this highlights the paucity of data for it. I mean, there really isn't much data out there for this. So luckily we were able to get enough to be able to find some conclusions, but this highlights why there wasn't anything else as far as any strong evidence to support any one type of resection over another. So we had 118 patients with gross total resection and 43 with subtotal. And here, just showing the follow-up, at least 8 of the 13 studies had greater than 50 months follow-up, which is really important for chordoma research because, I mean, as we know, these are, they're aggressive, but they're slow growing over time. So the studies included have to have years of follow-up to be able to determine what the actual outcomes are. Here, basically just showing each of the studies that we included, showing the number of patients, age, ratio of male to female, the number of patients with different types of resection and follow-up and things like that. So I won't dwell on this, but here it's kind of more of the meat of the study. So this is looking at progression-free survival. So in the first assessment, this is gross total versus subtotal. So that gross total, that's going to include en bloc and intralesional gross total. So there was a significant difference when you look at the progression-free survival with gross total patients having longer time to progression as expected. And then here we did a sub-analysis. We looked at en bloc versus subtotal. And here, same thing, also significant, but with a really low hazard ratio, which kind of indicates a stronger treatment effect. And then here for intralesional gross total, also significant. And here, just once again, really the main thing to point out is just the difference in hazard ratios. And kind of an honorable mention here, when you look at lesion location, although it wasn't significant, there was a near significance when you look at lesion location. So that's upper cervical versus lower cervical, as we kind of discussed before. So this is saying, so this is, these are all moderators of heterogeneity. What that means is that if this is significant, that means that that variable had an effect on whether they were able to get us, whether they were in gross total or in the subtotal group. So with this one being nearly significant, what that means is that the patients with upper cervical chordoma were more likely to have a subtotal resection. Not significant, but nearly. And here, same thing except for overall survival. Gross total resection, of course, that was significant. Intralesional gross total resection versus STR, that was significant. But surprisingly, I'll discuss this in a little bit, but surprisingly, en bloc resection was not. As far as reasons why, one could be the numbers, because when you look at, when you do the stats with these, the number of events is going to be what kind of determines, the results you're going to get. And there weren't that many, in general, there weren't that many patients with en bloc, but also there weren't that many events of death. So you need events of death to be able to, run the analysis successfully. So that may have been a factor because, I mean, these patients weren't dying, but.
How many en blocs did you have? Because you said only 2 before, but that was only in your independent students, right?
Yeah. So en bloc, there were 29.
29 total. Okay. Yeah, I see.
And then the other thing to highlight is that the number of levels and the effect on resection type, that was significant. So what that means is the more levels you had, the less likely you were to get a gross total resection, which, it's kind of intuitive, but this kind of just proves that. So here, like I said, we did an intent to treat analysis, and the results were mostly identical, except that there was a near significant difference now in the en bloc cohort. So what that means, or what that tells me, is that when you add the patients that had just attempted en bloc resection, even if the margins were violated, there was, although it wasn't significant, now there was a near significance in improvement in overall survival. So just to kind of speculate what that really means, I mean, does that mean that, okay, so just the act of trying to do an en bloc resection is going to improve survival for these patients? That's kind of what the data is pointing to, although, it wasn't significant, like I mentioned.
I think it, more than anything, it just protects the art of randomization, right? I mean, it equals the playing field, it levels the playing field. I think it's a really commendable part of the study. I think you guys did a great job with that.
Yeah, thank you. So in conclusion, this is the highest level of evidence there currently is for management of these patients with cervical chordomas. So gross total resection, whether that's with en bloc spondylectomy or with piecemeal resection, this shows that the progression-free survival is going to be improved. So these patients are going to do better and have less risk of the tumor coming back if you can get it all out. So just like the situation with cervical or sacral chordoma, if you can get it all out, the patients are going to do better. And then our meta-regression found that although they were both associated with progression-free survival improvement, en bloc resection had a lower hazard ratio for progression, which it could mean that maybe there's a little bit more benefit if it is feasible. But like I mentioned, it's not always feasible. I mean, for example, if you have a patient with cervical chordoma that encases the left vertebral artery and you do an angiogram and the left vertebral artery is dominant, I mean, you can't take it out. So in general, if you can get it all out with a piecemeal resection, that's fine, but en bloc still maybe a little bit more beneficial than intralesional resection. The only thing that kind of surprised me, like I said, is that the en bloc wasn't associated with the improved overall survival. I mentioned the thing about numbers. The other thought is, I mean, obviously there's going to be a bigger surgery, like the case I showed you, going to be longer hospital stay. Could that mean delayed radiation? And could that be a factor for the reason why the survival may not have been improved with them? It's hard to say. And unfortunately, the studies did not include radiation data. I think that was probably the major limitation of this study. I wish that all the included studies had some sort of radiation data because as we know, I mean, radiation is improving, but I did at least look to see the percentage of patients that had radiation for subtotal and gross total. And I think it was pretty much identical. It was like 43% and 58% in terms of the ones that definitely had radiation. So it didn't seem like that was a big difference or would have made a big difference in the study, in the outcomes at least. So overall, that's kind of the premise of the study. Like I said, sacral chordoma, there's a lot of literature out there, but there really isn't much of cervical chordoma. So hopefully now this kind of puts a stamp in the literature like, hey, this is something we should still be doing.
Yeah, I commend you. This is an excellent presentation and more importantly, an excellent report in Journal of Neuro-Oncology. Oftentimes we get meta-analyses, and meta-analyses are done for, in many instances, the wrong purposes. What you've done is done the meta-analysis elegantly and put together your own clinical data, pulling from multiple institutions, getting the thought leaders involved in this, and then targeting a rare indication, rare type of tumor, and then thoughtfully analyzing it. And I love the intent to treat analysis too. So, I mean, it's if I can say anything as sort of editor for the journal, I'd say, this is the perfect example of when to do a meta-analysis in neurosurgery and to do it well. And then I'll just add, I think this really is the new standard in terms of references for this particular subject. You've done a great job, and it's a thoughtful analysis. So
I want to follow up on that. Olu did a really spectacular job. Olu, if you stop sharing your screen so I can see the faces of the people, at least who are on the call, you did a spectacular job with this. This is really, this is a very difficult question to answer. And that really, I think Olu found a way to be able to extract the data from the literature and combining with their own experience from Mayo Clinic and being able to answer some critical questions. But I just want to take a moment here and share my own personal observations and how they were really confirmed with Olu's study here. I think that the take-home message from this is, number one, is that the more complete the resection of the tumor is, and I'd probably true anywhere in the mobile spine as well as in the sacrum, the better the outcome is going to be. So if you're able to do an unblocked resection with negative margins, with wide margins, better. Marginal margins, better. And if you're going to do an intralesional resection and you're committed to do that, trying to do that as completely as you can, the outcome is going to be better. And I think that that's what the study is alluding here. And you also noted that the initial size of the tumor is a determinant of how successfully you are achieving that complete resection, right? So if you start with a 200-300 cubic centimeter tumor, getting an unblocked resection is more challenging than a much smaller tumor. You also noted that the more levels are involved in the spine, the more difficult achieving a complete resection. You also demonstrated that in the upper cervical spine, as compared to the lower cervical spine, the situation is more challenging. And so I think that the take-home message from this is that you always have to weigh the magnitude of the surgical procedure, morbidity of the operation, the patient's overall risk tolerance, and their medical fitness for the surgery that is proposed. But the general principles, the more complete the surgery is, the better the outcome is going to be. There is definitely some benefit that comes from the radiation therapy. I think you have some data suggesting that in your analysis, although the study was not geared to answer that question, you've demonstrated that there is some benefit that comes from the proton beam radiation therapy or other types of high doses of radiation in a conformal manner delivered to the target. And you noted that the patients who had more than 70 gray of radiation perhaps fare better than those who received the radiation to a lesser dose. And so I think that general principles of how to manage the chordoma are all beautifully illustrated in your meta-analysis within a relatively limited number of patients. And yet, I think that biologically answered a lot of questions here. And I think that's the reason why I think this study is commendable. And I have to tell you that Ola deserves all the credit for this. He did all the work and worked with the biostatisticians, extracted as much information as possible from a limited number of papers out there. And congratulations. Beautiful work.
No, thank you. No,
Absolutely, man.
It's definitely a team effort because there were a lot of things that were added, especially by Dr. Coslin. I remember it was a Sunday afternoon. I think I was driving back to Jacksonville from Atlanta and stopped and we chatted, and he really highlighted the whole concept of radiation. So I added a little bit more, and we came up with the whole intent to treat analysis. So definitely a group effort, and luckily we were able to end up with a good paper in the end of it.
Yeah, well,
fantastic.
Great papers come with great young investors like you, but also with the mentorship and leadership that Zia and Kingsley no doubt gave. And so, my hat's off to you. I think this is a marvelous study, so well executed, so well done, and so thoughtful. And it really is going to be the guiding paper, I think, for years to come. I'll throw out one other concept, and I just your thoughts on these tumors are so rare, and clearly you've demonstrated the value of multidisciplinary surgeries and extent of resection. Is there not a better case to be made than this for really being thoughtfully done at centers of excellence for spinal oncology? I mean, this is not your run-of-the-mill tumor that I think you're going to want to treat at a regional center or a community center. This is really something that probably is best, with all due respect, I think referred to some places that really are going to push the multidisciplinary surgical approaches, are going to do that conformal high dose radiation to follow if there's something there. These are not the typical spinal oncology cases that we're all going to see as part of a standard practice. It may be surgical neuro-oncology based. This is such a rare entity. But what are your thoughts, Zia, and particularly interesting.
So this question comes up all the time, and as a matter of fact, anytime I give a talk, this type of question is posed. Do you think that all these patients really should be referred to a handful of specific centers in the country to do these types of procedures? When it comes to metastatic spine disease, I feel that every center really should have a high level of expertise in dealing with those, because they are urgent, emergent cases, and you have to deal with them. And hopefully you will do the right thing for those patients. And most institutions have great people who can handle them. These are, I think. I'm sorry.
Don't you think this is so distinct from those? I agree.
That's exactly what I was about to say. This is very distinct. These are very rare tumors, and decision making is very, very complex. It's just not, you can always go out there and say, it's a chordoma, you should do an en bloc resection. Well, it depends on where it is, how extensive it is, how old the patient is, and you also demonstrated in your work that older the patients are, the worse their overall prognosis is. And I think that this is true across the whole oncology field in general. So yes, I 100% agree with you, Jason, there. I think that these specific primary tumors that are really surgically very demanding cases and multidisciplinary approach really can make a difference in the long run. I think they should be referred to centers that are specialized in doing them. And I think that we do have all of these centers on the East Coast, West Coast, in the North, South, and in the central part of the U.S. And so I think we need to be thoughtful about sending these patients to the right places. And the other thing is the radiation piece of this, equally important because it needs to be planned. You cannot really put a bunch of hardware and create enormous amount of artifact and then send the patient to a proton beam radiation center and say, go ahead and radiate this patient, because it presents a lot of challenges to be able to deliver the appropriate dose to the target. And there has to be very close communication between the surgeon who did the operation, where they are concerned about the margins and where the highest dose is going to be delivered. And that needs to be communicated clearly to the radiation oncologist. For all those reasons, I think sending them to specialized centers are very critical.
Yeah, I 100% agree. So thank you.
Yeah. Guys, we have about a minute left. I just had one last question for you. And it has to do with this last data point, the tricky data point about the fact that the en bloc wasn't necessarily different than the intralesional. And my question for you, Dr. Gokazan, since you're really the expert here, is does it change your practice a little bit? Are you less inclined to do an en bloc sometimes, knowing that the intralesional is what your study shows itself is giving the best possible outcome here?
So I don't interpret the study result as such. All I'm saying that I think that what the study is saying is not the gross total resection, intralesional gross total resection is equal to en bloc. I think that what the study is saying is you should really do whatever you can to get it as complete a resection as possible. If possible, do an en bloc resection. If not, if you are committed to doing an intralesional resection, which you are forced to do under certain circumstances, and then make sure that you resect that tumor as completely as you can, and so that when you do a post-op MRI scan, there is really no tumor left behind. And then finally, if you look at patients that are actually cured of their chordomas, 10, 15, 20 years out, none of them had an intralesional resection. Virtually all of them had en bloc resections of the negative nodules. And so if you have an opportunity to achieve that, go ahead and do that. The other thing I think that the very significant information that came out of the paper is that when we do an en bloc resection, we plan the operation with an en bloc and we execute it as such, and then you end up entering the tumor, or you get a path report that says your margin is positive. Is this the same as doing an intralesional resection? My answer is no. I think that operation that you did in an en bloc fashion was a more complete tumor operation than you would have achieved with a gross total resection. And hence, you should really design your operation, if it is possible. I'm not saying in every case, so it's possible as an en bloc, knowing that you may end up entering the tumor. But even then, I think your results are going to be in the long run better than just planning a gross total resection from the start. And so that's how I interpret the data. But on the other hand, if the morbidity of the operation is really unacceptable, location is so difficult, and you're giving a patient a significant neurological deficit, then you have to be thoughtful and say, I don't think that it's worth attempting an en bloc. Let's do a good operation, intralesional resection in this patient.
Yeah.
I think that's a great response. Yeah, great response. I think very well thought out, and obviously with a lot of experience to back that up. What were you going to say, Olu?
Yeah, no, I was just going to say I completely agree. And unfortunately, we weren't able to look at a direct head-on between en bloc and intralesional gross total. That's what I really, really wanted to do, but we didn't have enough incidences in those groups to be able to do that. But like I said, at least we saw that when you compare the en bloc to STR, and then you compare intralesional to STR, at least the hazard ratio was lower, which, like I said, could mean a stronger treatment benefit. And then the intent to treat analysis also kind of correlates with maybe a little bit of an increase in overall prognosis, because when we added those patients to the en bloc group, so even if the ones that had violated margins, when we added those to the en bloc group, there was a near significant improvement in overall survival. So at least, maybe it shows that there's a little bit of a difference between them, like Dr. Cookhouse alluded to.
And just one last comment. Sometimes when the disease is circumferential, both in the anterior and posterior part of the individual segment, the people say, okay, you cannot really do an en bloc resection here because you have to enter the tumor. And I would respectfully disagree. In that situation, you can design an en bloc operation with a planned transgression of the tumor, cutting through the pedicles bilaterally. I would still argue that operation that you do in that situation is much better on the long run in terms of local recurrence and overall survival than coming to the conclusion that since I cannot do an en bloc resection, I have to enter the tumor. Let me just do an en bloc do an intralesional resection here. So if it is possible that you're going to cut the tumor, but you can still get all of it out, plan it as such over just doing what we call a true intralesional resection.
Absolutely. Well, guys, that's about all the time we have. I want to thank you all for being here. It's a fantastic session. And we look forward to the next publication in the JNO.
Thank you. Thank you for having
me. Thank you so
me.
much. Thanks. This was a great platform. I look forward to more of these. Thank you.
Really enjoyed it.
Take care, guys.
Thank you, Jason. Thank you, Randy. All a great job as always.
Of course. Thanks.
And call Dave Langer, Zia.
I will do that. Thank you.
Take care.
Oh, and actually, I spoke with Dr. Bukbar this morning. Dr.
Oh, yeah,
he walked.
Yeah, he walked.
Yeah, he gave a talk this morning. He's a great guy.
So funny. All right, man. Take care. Bye-bye.
Bye.